I am very excited to be here with everybody today to talk about dental infection prevention and control. And I'm so excited to see that there are people from all over the country. So this webinar is approved for continuing education, and we're going to go ahead and get started with our learning objectives. So the goals for today are to talk about the CDC's guidelines for infection control in dental health care settings. We're also going to look at the instrument sterilization process in the dental setting, which has some specific challenges that are different from other healthcare settings. And then we're going to look at a ton of dental infection prevention and control resources throughout the presentation. So be ready to take pictures of the slides if you want those resources, and we will get started here. So before we get started on the CDC recommendations, I wanted to give a bit of a background on the potential for the spread of infection in the dental setting. And because we are working with Project First Line for this presentation, we're using some of their concepts. So in order for the spread of infection to occur in any healthcare setting, there are 5 different factors that have to take place. So the first, we have to have a reservoir, or where the germs live. We also have to have a pathway, or how the germs travel. We also have to have a person that's susceptible to that germ. We have to have a germ that can survive, and we also have to have a break in the body's defenses. So it's really a common misconception that all of these factors have to happen in order. They really don't. They do, however, all have to be present in some capacity for that infection to be able to spread in a healthcare setting. And just like other healthcare settings, dental settings have reservoirs, pathways, people, germs, and ways to bypass the body's defenses. So this means there's the potential for that spread of infection in the dental healthcare setting. And as dental healthcare providers, we also have a responsibility to be able to recognize that risk and take action to stop the spread of infection. So another concept from Project First Line is looking at the different types of reservoirs that are out there. So we're going to look at some environmental reservoirs in the dental setting. The first one is our water and wet surfaces, and you can find water and wet surfaces everywhere in the dental setting. So some common places would be our dental unit water lines, our huge harbors of bacterial activity. Faucets and drains also can harbor pathogens, as well as our sterilization area tends to stay wet all day long because we're rinsing contaminated instruments, we're working with the ultrasonic cleaner, and there's just water everywhere. Dry surfaces can also harbor those germs. So things like countertops, other clinical surfaces, switches, handles, the patient chair, the floor. There are dry surfaces all over a dental clinic that have the potential to harbor those germs. Dirt and dust can also carry pathogens. So there are pathogens in HVAC systems all the time. If you think about potentially what's living in the HVAC system in your home, if you have pets, there's dust, dander, there's the potential for germs to be there. There's also the potential for those germs to live in maintenance, construction, and repair dust. So if you're doing any sort of construction, there are infection prevention and control processes that you can look at to help minimize that dirt and dust. And the last environmental reservoir is a device. And we have tons of specialized devices in the dental setting. These could be our instruments, our dental handpieces. We have X-ray equipment. There are a lot of very intricate pieces of digital imaging equipment that we use, and all of these devices have the potential to harbor those germs. Pathways in the dental setting are also very common to other healthcare settings. So there are 4 different pathways we're going to talk about. The first pathway is through touch, and this could be either direct contact or indirect contact with blood, other potentially infectious materials, a contaminated surface, a contaminated instrument. There are just a lot of different ways that we can transmit those germs through touch. They can also be transmitted via aerosols and breathed in. So breathing in those aerosols actually bypasses the body's defenses by putting those germs directly into your lungs. And there are a lot of procedures in dentistry that are considered aerosol generating procedures and have the ability to put those germs in the air where we can breathe them in. There's also a lot of instances of splashes and sprays in the dental setting. And these can be from the dental procedure itself with the air water syringe, with our patient's saliva, and in the sterilization process, like I mentioned before. In dentistry, we also do a lot of procedures that break down the body's natural defenses. So those operative dental procedures, oral surgeries can bypass the body's defenses and provide a direct route into the patient's bloodstream for those germs to access their system. And even those procedures that you wouldn't think would be invasive still have the potential to provide access to the patient's bloodstream. If you have not yet seen the video, If Saliva Were Red, I would recommend everybody take a few minutes. I think it's only about 8 minutes long. Search it up, go watch it. And it gives you an idea of how much splash, splatter, spray is involved in a dental procedure. So I've got the link on this slide. You can also Google it. The Association for Dental Safety recently refilmed this video, and it's a very famous video. It was originally filmed in the late 80s, and it was just recently updated by ADS. So check out their website and the video if you're interested in seeing how dirty or contaminated a dental procedure can be. So as providers, we should be able to look at our reservoirs, our pathways, what germs we're exposed to, and recognize that risk and take action. So understanding where the germs live, how they travel, can all be an influence in how we take action. So things like wearing the proper PPE, cleaning and disinfection, our sterilization processes. Those are all ways that we can take action to help prevent the transmission of disease in the dental setting. So now we've talked about kind of the progression of disease transmission. We're going to get into some of the CDC recommendations. So throughout the rest of the presentation, there are going to be QR codes on a lot of the slides. And this is where if you want to take pictures of these slides, please do. They're all great resources that are freely available to everybody and can really help with your IPC programs. So the first resource I wanted to mention is the CDC's Morbidity and Mortality Weekly Report, the Guidelines for Infection Control in Dental Healthcare Settings. And this document was published in 2003. And it is really a deep dive into the science of dental infection control. It's an extensive document. It's a little bit hard to read. It's almost like reading a journal article. But for the longest time, this was our standard for infection control in the dental setting. In 2016, the CDC took that document and made a summary of it. So that's what some people call the Blue Book. It is the summary of infection prevention practices in the dental settings, basic expectations for safe care. And this QR code will take you to their website with a summary of this document. But on that website, there is also access to be able to print off the PDF version of this booklet. And you can even order free hard copies for your facility or your organization if you want to. So I encourage you to go check those resources out, especially the Blue Book. It's a great one to have on hand for dental infection control. So in the Blue Book, there are different domains that have to do with infection prevention and control. And for each domain, they have this little blue box that is their key recommendations for each different domain. So we're going to go through all of our domains' key recommendations. And the first one is those administrative recommendations. So any effective IPC program has to have an administrative component. This administrative component should include things like written policies and processes, and ensuring there's at least one person responsible for the IPC program that's had education in infection prevention and control. Another aspect of these administrative processes is creating a policy and process to identify individuals that could be potentially infectious when they arrive at your facility. And we all did this during the COVID-19 pandemic, and we should all consider continuing to do this because right now we're on the cusp of respiratory viral season. There are some other illnesses out there that are pretty prevalent in different areas, and preventing those sick patients from coming into our facilities can help prevent the spread of transmission by process of elimination. If we can reschedule them before they even sit in a chair, then they're not bringing those germs into our office, and they're not potentially contaminating other patients, their environment, and our healthcare staff. Right, seeing about letting other people in that are waiting. All right. So our next domain is program evaluation, which is another important part of any IPC program. So the policies and procedures that are developed should be evaluated regularly, at least on an annual basis, and if things change. So if we get a new piece of equipment, if we have a new process, those policies surrounding those new pieces of equipment or processes should be added to your policies and also included in your training. And that way you can keep your policy and your program up to date and keep it all rolling as it should be. A great way to do this is with a standardized tool. So the CDC has created this awesome app. It's called Dental Check. And it basically is a standardized checklist for your dental infection prevention and control program. So it consists of two different parts. There's the policy and practice section, and then there's a direct observation section. So this is free for anyone. You can download it from the Google or the Apple Store, and you just go in, start a new checklist, and you answer these yes/no questions. You can put notes in for each question, and then when you're finished, you can export it into a PDF version that can be a part of your program evaluation and compare your notes over time. So if you do this every year for 3 years, you can see where you're improving. You can see where maybe you need improvement. And it also gives you all the resources you need to be able to support program improvement. So another great resource for everybody out there in the dental setting. All right, so the next domain is education and training. So facilities should be providing education and training for their staff, and education and training are two different things. So education is what we're doing today. Training, think about like hands-on training. But the office should provide that job or task-specific education and training to all of their staff before they start working. So the education and training program should also include if they have contractors or volunteers or students that come into the facility, all of that training should apply to them as well. Should be based on both staff safety, and patient safety. So I know OSHA bloodborne pathogens training is a very common one. I do a lot of bloodborne pathogens education for people. And when I go into their facilities, I tell them, you know, that this education I'm providing today is great, but I don't know your facility policies. And I don't know what equipment and what cleaning chemicals you're using. I can't provide that training during my regular OSHA education. So it should be specific to what's going on in your dental facility. Should also be providing training on a regular basis. So like OSHA is required to be provided annually. You can do it more often than that. But make sure that if anything changes or is updated, you're providing education and training on those things when it happens. And then you should also be maintaining training records according to state and federal requirements. So a general rule of thumb for OSHA is to maintain those records for at least 3 years, but your state requirements could be more stringent. You may have to keep them for 5 years or 7 years. So check out your state guidelines before you start purging any of your training records. Another great resource from the CDC, we talk a lot about the CDC today. This is an online course that they have that is free to take. It's called Foundations, Building the Safest Dental Visit, and it is a 3-hour course that is specific to dental infection prevention and control. So it's a really great back to basics course. It's great for new hires. It's great for students. If you are a dental professional that needs CE, it also comes with 3 hours of continuing education attached to it. So once again, another great resource for everybody out there. And if you scan this QR code, it will take you to the webpage where you can register on the CDC Train website to take the course. All right, next we're going to talk about the key recommendations for dental healthcare personnel safety. So with our personnel safety, this should be a part of your policy and procedure, protecting your staff. Immunization is a huge part of this. So OSHA has requirements surrounding hepatitis B vaccination because it's one of those 3 major bloodborne pathogens and the only one that has a vaccine available. But it's not the only immunization that healthcare facilities should consider. So the CDC has a great list of recommended vaccinations for healthcare workers that a facility they can take and put into their policy for their staff. So do you want your staff to have the MMR vaccine, varicella vaccine? Are there others that you would like to include in that? That's really up to your facility policy. Tuberculosis or TB is also another consideration. And regardless of TB risk, employees should be screened upon hire. Now, that doesn't mean they need a TB titer skin test, but they should at least be asked screening questions about their history and their potential of exposure. So if in their previous job they worked with a high-risk population, then maybe they do need that TB skin test. You should also consider screening for your staff if you are in an area that TB is of higher prevalence, or you're in a facility that treats a population that is at high risk for TB. And then lastly is the facility having a robust occupational exposure program. So this is an area that I see a lot of opportunity for in dental facilities. A lot of staff know that they need to do something after an exposure incident, but they don't know what. And oftentimes that what ends up being, I'll go to the ER. But facilities really should have a process laid out for their employees so everybody knows exactly what to do if they have that exposure incident. So they know to stop what they're doing, wash the area with soap and water, report it to their manager, and then go see that healthcare provider that's qualified for occupational health to be treated and have those follow-up visits if necessary. All right, next is hand hygiene. I always hear a lot of groans when I talk about hand hygiene. I think we're all adults. I don't need to tell you how to wash your hands, but hand hygiene is such an important part of IPC programs in dentistry and in other healthcare settings. It is also a huge gap in dental facilities and other healthcare settings. So the facilities should have that policy on hand hygiene that includes how and when hand hygiene should be practiced. They should also provide training and do some competency checkoffs with hand hygiene as well. In their policy, it can include things like when to use soap and water versus when to use alcohol-based hand sanitizer. Usually, if hands are visibly soiled, you can see stuff on them. And visibly soiled includes sweat, even though sweat's clear and you may not be able to see pieces of dirt or anything, you can still see that your hands are wet. That really shows the need for that soap and water. If you're practicing hand hygiene and there's no visible debris on your hands, hand sanitizer is great. So make sure that hand hygiene is practiced often and well, and you're providing hand hygiene supplies everywhere. If things are sitting out, people will use them. So put your hand sanitizers on all the counters. All right, next is our key recommendations for PPE in the dental setting. So generally, dental providers should be practicing standard precautions during treatment. And wearing appropriate PPE based on the exposure risk of the treatment that they're doing is a big part of that. So we think back to the pathways we talked about. The nature of the procedures in dentistry leads to the potential of a lot of splash and splatter. And this means that we should be wearing gowns, masks, protective eyewear, and gloves during treatment because there is the potential that we could be covered in that splash and splatter. As far as our training and education goes, the facilities should provide education and training on the type of PPE to wear for each procedure. It should also include how and when to don and doff their PPE and how and when to properly dispose of their PPE. So these PPE education and training should be very robust and not simply here's a box of gloves, use them. A great PPE resource from the CDC, they have these wonderful donning and doffing sequence posters. So there are a couple of different techniques that you can use for doffing. So there are two different posters here for doffing. Generally, donning PPE one way, but depending on the type of PPE you use and personal preference in your office, you could doff a couple of different ways. I would recommend, though, that if you're using these flyers, to pick one technique and roll with it. Because if you are learning both techniques, that can be confusing for staff, and they may not know how or when to practice each technique. So pick one and stick with it. Make it easy for your staff. These PDFs can be printed out and laminated and hung up in your office if you want to. There are also some great videos that the CDC has on how to don and doff that go through each of these different techniques. So you can find those on their website as well. All right, the next domain is recommendations for respiratory hygiene and cough etiquette, which once again is pretty standard across healthcare settings, right? We want to contain our coughs. We don't want to spread those germs around. So this is really management of our patients when they're coming in to our facilities. And like I said before, this was really on everyone's radar during the COVID-19 pandemic. We all had PPE stations, we had hand hygiene stations, we had the cover your cough signage, which was fantastic. And I've seen more and more that those things have gone away because the pandemic is over. but we're still going into respiratory protection season. There are other diseases out there that could be transmitted. H5N1 was in the news recently. So having these PPE and hand hygiene stations for your patients is still a great idea. It's still a great idea to have the signage available, the cover your cough signage, or if you want people to wear masks in your facility if they have symptoms, that's a great option as well. Another thing you can do is screen your patients. And this can be as simple as asking them if they have any respiratory symptoms during their appointment reminder call or when they walk in the door to check in. And if they do have symptoms, it may be best to reschedule them. I know that puts a hole in the schedule, but we don't want to be doing an aerosol generating procedure or something that's going to cause a lot of splash and splatter if that person has a respiratory illness, because there's a higher potential that that will spread around your office. So Project First Line has some great signage and graphics for respiratory hygiene and cough etiquette. So this QR code will take you to their website where there is a whole list of these different signs. So you can print these out, you can laminate them, hang them up around your office. There are signs on covering your cough, wearing masks, practicing hand hygiene. So posting these around for patients and staff, if you need to, is just a really good, easy reminder. And there is such a thing as signage fatigue. So if you find that people are starting to ignore your signs, switch them up a little bit, move them to a different place, put a new sign out, change colors, something to grab their attention so they're still looking at those signs. All right, our next recommendation is sharp safety. So sharps are something we deal with on the daily in dentistry. You'll want to make sure that facilities are identifying what sharps are in their facility. So some general sharps would be our anesthetic needles, scalers, dental burrs, lab knives, orthodontic wires. Are we considering wedges as sharp or anesthetic carpules as sharp? All of those sharps should be disposed of in a sharps container that is color-coded and labeled as a biohazard. Also having policies on the management of sharps is important because we want to protect our staff. So making sure it's written in your policy not to recap needles using the two-handed technique. Never do this. That will always end in an exposure event. If you don't have sharp safety devices, needle recapping devices, using a one-handed scoop technique is the best way. Also considering on getting those needle recapping devices in your facility is a great thing. They can help keep your staff safe and reduce the amount of exposure incidents. The CDC has some dental-specific sharp safety device evaluation forms available. And really, your sharp safety devices should be evaluated on an annual basis. And these forms give you a really nice objective way to evaluate those. And when you evaluate sharp safety devices, everybody that uses that device should be included in the evaluation. And you should really talk about it as a team. And, does this device work for us? Do we want to commit to using it, or is it something that's not going to work for us? And using these forms for documentation is a great way to go through all of the pros and cons with your team and talk about it and really decide which sharp safety devices are right for you. All right, next is our safe injection practices. Sharp safety practices are really designed for employee safety. Safe injection practices are designed for patient safety. So these are things like preparing our injections in an aseptic manner, preparing them in a clean area, not using our needles or syringes for more than one patient. Everything should be single use when it comes to needles and syringes. And then prioritizing the use of single-use medication containers. So our anesthetic carpules are single-use, right? We would never take a carpule out of a syringe and use it on another patient. But there are certain instances where you may be using a multi-dose vial for other medications. If you're doing cosmetic injections or some other procedures that involve those multi-dose vials. And if you are using multi-dose vials, there are special considerations for those. If you can dedicate it to a single patient, that's fantastic. If you can't, make sure that it does not go into the patient care area. And if that vial does go into a patient care area where it could potentially be contaminated, it should be considered single use after that. You cannot effectively clean and disinfect that vial. Should also be making sure that the vials are labeled appropriately for their expiration date. So unless there is something in the IFU that says otherwise, usually it's a 28-day expiration date once that vial has been opened. Same goes for IV administration. Make sure those IV sets are single patient use. So you would never use the same bag, tubing, needle, connections for more than one patient. All right, our next key recommendations are environmental cleaning and disinfection. Sorry, a little tongue-tied there. So having policies on your environmental cleaning and disinfection practices is going to be important, and then training all of your staff so they know exactly what they're doing. Using a two-step cleaning and disinfection process is also important, and another opportunity that I see in offices. Oftentimes the staff don't know that it's a two-step process. So they're wiping their counters down with their disinfectant and they're letting it sit for the 2 minutes, but they haven't done any pre-cleaning. So reviewing that with the team and including that in training is an important step. And then selecting the right disinfectant. The Environmental Protection Agency manages the disinfectants, which are actually considered pesticides, and they have certain registration lists that your disinfectant should be on to make sure that they are effective. Should always follow manufacturer's instructions for any of the cleaners and disinfectors that you have in your office, and that includes the amount used, dilution, if it's a diluted chemical, your contact time, what PPE is required, and then any appropriate disposal. Project First Line created this great poster on how to read a disinfectant label because there is a lot of information on those labels and it can be very hard to decipher exactly what's going on. So if your staff have questions and need a little bit of help with that, this is a great poster to put in the break room. They should be able to know what PPE should be used, what the contact time is for that particular disinfectant, and how to dispose of it properly. This is an example of the EPA registration list, and there are a lot of them, but you will want to focus for dentistry on those intermediate level disinfectants that are effective against tuberculosis. So that is our list B, is effective against tuberculosis. And then they recently combined some other lists into a new list, list S, that is effective against the bloodborne pathogens. So HIV, hepatitis B, and hepatitis C. So any disinfectant in a dental facility should be in both of those lists, B and S. All right, our next domain is dental unit water quality. And this is really one that's specific to dentistry and not really translated to other healthcare settings. So the CDC says that the water we use for dental treatment should meet the EPA standards for drinking water, which is less than 500 colony-forming units per milliliter of heterotrophic water bacteria. And that standard is pretty general. And there is a lot of confusion in the dental community about what water do I use? Does it work with my dental unit? Am I using the right maintenance chemicals? Am I using the right shock chemicals? And it really all depends on the IFUs of everything you're using. Some require distilled water, some required filtered water, some required tap water. It just really is all very situational. Another thing to consider in dental unit water quality is that if you're doing any sort of surgical procedures that would expose normally sterile tissue, then you should be using a sterile saline or sterile water as an irrigant and not your normal procedure water that comes out of your dental unit, because that water does not meet the standards for those surgery procedures. A tool that we developed in Nebraska, we really noticed a lot of people were confused about dental unit water lines. So this is a great tool that helps people understand the risks that are involved and how to best maintain, test, and monitor water lines. And while this topic is specific to the dental setting, there are applications in other settings. If you work in an acute care facility that has dentists come into your operating room for privileges, there could be dental units sitting in a closet that they use once a week or twice a month or whatever that have water lines in them that should be monitored, should be tested, and should be treated. So this document also goes through what a dental unit is, what they look like. So if you're in those other settings, you can recognize that equipment and be able to take action. All right, our last set of key recommendations is for sterilization and disinfection of our patient care devices. So making sure we clean and reprocess those reusable instruments and equipment appropriately before they're used on another patient is very important. Everything should be cleaned and reprocessed according to the instrument IFUs, and having those IFUs available for everything is also very important for your staff. If they have a question about what sterilization cycle they should be running, it will be found in the IFUs, and they should be accessed easily. Should also be assigning responsibility for that reprocessing to your staff. So who is responsible for it? And are you providing the appropriate training for them to be able to do it in an effective fashion? Should be wearing appropriate PPE, which includes our utility gloves when reprocessing instruments, and then also should be using mechanical, chemical, biological monitoring to verify our sterilization success. So because this is such a complex process, we're going to go through it step by step, and it really is an instrument cycle. It starts with patient use and intake, and instruments are continuously going through this cycle of intake, pre-cleaning, packaging, sterilization, inspection, storage, more inspection, and then patient use. And each step is very involved, really. So when we talk about intake, it's more than just taking your instruments from the operatory into the sterilization area. You want to make sure that you're having our point of use cleaning done in the operatory and our point of use disposal. So if you have instruments that have gross bioburden on them, they should be cleaned at point of use using a damp gauze or a damp paper towel. Also should be disposing of all of our sharps in the operatory at point of use. Never transport sharps. When we're ready to transport our instruments, they should be transported in an OSHA approved container, and that should be puncture and leak proof and latchable or lockable. So this tub here is a great example. It's just a Tupperware tub. You put your instruments in there. The lid snaps on, so if you drop it, the instruments don't spill out. And it also has this biohazard sticker on to indicate to anybody that they're contaminated instruments. When we get to our pre-cleaning area in sterilization, there are a couple different ways we can pre-clean our instruments. So there are automated ways, and then there are the hand scrubbing ways. And we want to lean toward the automated ways because they take our hands out of that cleaning equation and reduce the risk for exposure incidents. So our automated methods would be our ultrasonic cleaners and our washer disinfectors. And each of those are, they'll have their own IFUs. They'll both have chemical solutions that should be used with them. And those IFUs specific to the machines, the equipment, and the chemicals should be followed. If your automated cleaning method does not get all of the bioburden off of an instrument, then we can take it and do some hand scrubbing. But if we're going to do that, we want to make sure we're protecting ourselves from the potential for that stick from an instrument. So wearing utility gloves, puncture-resistant utility gloves, and then scrubbing the instruments underwater to reduce the splash and splatter is also an important part of protecting ourselves. Packaging the instruments. We really want to make sure those instruments are thoroughly dried. If you have wet instruments in wet packages going into a sterilizer, you're going to have wet packs coming out. So make sure all the instruments are dried, and then whatever packaging you're going to use is really dependent on the facility needs. So if you're using loose instruments versus cassettes, you may use pouches versus the blue wrap. It really just kind of depends on what's going on in your office. After things are packaged, we're going to sterilize. And the great debate in offices is paper up or paper down in the sterilizer. And the answer is really, it depends on your sterilizer. There are sterilizers that require the paper up on the packages and the paper down. It all depends on where the steam is coming from in that sterilization chamber. So check your IFUs. There are special pieces of equipment as well, like hand pieces. And some hand pieces require a lower temperature or a shorter time for that sterilization cycle. And if they're run on inappropriate cycles, it can actually lessen the lifespan. So you'll have to replace those sooner. Sterilization maintenance is an important part of a successful sterilization process. If your sterilizer is not being maintained, there's greater chance that it will fail. And there are maintenance procedures that staff can do internally, but there are also things that should be done by a technician that knows how to work on those sterilizers. And any maintenance that's done should be documented and recorded in case of an audit. And then we wanted to talk about that validation testing. So there are a couple different types of validation testing that should be done with the sterilization process. So the first one is a type 1 indicator, which is a single parameter test. And that just measures that the sterilization cycle got hot enough. It's a temperature indicator. Every package, every pouch, every cassette should have an internal and an external indicator. The next step up is a type 5 integrator. So this is a multi-parameter test. So it measures that cycle got hot enough for long enough at the correct pressure. And there should be at least one of these type 5 integrators in every load in a process challenge device. So whatever your normal packaging is for the office, put a type 5 indicator in that. That's your process challenge device in the most difficult to sterilize area in the chamber. And if this is successful, then everything else in that chamber is successful as well. Our last type of validation is biological monitoring. So this actually has bacterial spores in these little vials or in the strips. And you run it and it gives you confirmation that your sterilizer is actually destroying those bacterial spores. There are mail-in and there are in-office incubation types. I always recommend the shortest timeline possible because if you have a test that fails, you have to pull all of your instruments from the last past test. And if you're using a mail-in test, that could be a week where you've already used some of those instruments and you're unsure if that sterilizer was actually functioning for all of those instruments. So if you can use the fastest test available, you're going to get the best results. Once our instruments come out of the sterilizer, they should be inspected. And you should be looking for a couple different things. The first thing, which is pretty easy to see, are wet packs. So you can see in the picture on the left, there is water in that package. Wet packs will actually wick bacteria and viruses into the package, rendering them non-sterile. So if you have wet packs coming out of your sterilizer, they should be reprocessed. They are not considered sterile. If you have holes in packages, those instruments should be reprocessed as well. And then once everything has been inspected, it all looks good, we should really be storing it in a closed or covered area away from splash splatters and aerosols, because if that paper gets wet, then it's rendered non-sterile. So keeping them in cupboards or drawers is a great way to kind of help protect the packaging once they've been sterilized. And then last is our inspection and patient use. So we pull instruments out of that storage, covered storage, where they've been dry and kept clean. We want to inspect the packages again, because you never know when an instrument can poke a hole in that packaging. If there are water spots, if there are oil spots on that packaging, if the indicators did not change, and then it's not a successful sterilization. So taking a look before you use them on a patient after storage is also very important. And then once they're used for patient use, they start back through this cycle. So sterilization is really super involved. I could spend probably 3 hours talking about the sterilization process, and I know we talked about it very quickly, but we are coming up to the end of the hour. So I've got a few key takeaways for you. So the first one is to check out the CDC guidelines for infection control in dental healthcare settings. Both the MMWR and the Blue Book are great resources and can give you an idea of what is recommended in the dental setting. It is important to note, though, that state requirements may be different than CDC recommendations. So check your state Dental Practice Act. Some states have CDC recommendations written into law, where you have to follow those recommendations. Some states don't. Some states are more stringent and you have to do more than what the CDC recommends. So check your state laws and see what is required. Second key takeaway is that the instrument sterilization process is super complex with many steps. There are a lot of opportunities for process errors. So doing some audits in that area and making sure your processes are set up where they need to be will be important to have that successful sterilization. And last key takeaway is that there are a ton of dental specific resources out there that are available. The ones I've provided today, it's not an exhaustive list. You can find so many more. And I'm always happy to help find resources for anybody if you have questions about a specific situation. Part of my job is being a resource library. So if you need it, I've probably found it at one point in time. When you get this slide deck, all of the references, the links are live. So there are 3 slides of references on here. And with that, I am going to hand it back over to Tyrone for Q&A if we've got any questions.